Good morning, and welcome to this extremely sensile session on the complications in cataract surgery, innovative and practical tips in the management. So we have distinguished speakers in this session, and I'm sure that this session is going to be rich in teaching, and you'll see many innovations what we have been doing in cataract surgery. And I will request.
I think sir is loading. So shall I go and present first?
You can go ahead. Yeah, sure. So Dr. M. Naveen is, you all know him. He's a very proficient cataract surgeon, and he's going to talk on zonular dialysis, its prevention and management.
Thank you, sir. So, respected teachers, senior ophthalmologists, my dear friends. So, I'm Dr. M. Naveen from MN Hospital, Chennai, and I'm going to talk about zonular dialysis management. So, as you all know, it can be graded into 3 types: the minimal, moderate, or the severe types, depending on the degree of weakness of the zonules, up to 4 clock hours and more than up to 180 degrees of zonular dialysis, and then more than 180 degrees. So according to the degree of the dialysis, the treatment and the different options that we are going to choose in managing them will vary. So then again, and also depending on the type of cataract, whether we had associated with the softer cataracts or harder cataracts. So before we start the preoperative evaluation, we should also know what all the signs to look for when we have a case of zonular dialysis. You would all notice that during the rhexis at some point where the zonules are weak, you have the wrinkling of the capsules that is noticed. So that is because there is no counter-traction of the area where you're doing the rhexis. So in those cases, it's better to do with the capsular rhexis forceps than doing a cystitome. Then you get this unusual movement of the lenses, you have these phacodonosis, and sometimes when the zonular dialysis is more, you have the vitreous that is prolapsing outside. So what this tells you is you should always be ready with the vitrectomy setup also when you manage these cases of zonular dialysis. So let me just go through some case scenarios. One second. Okay. Sorry. Can I just... Yeah. So the first case is going to be a case of iris coloboma, a mild coloboma, and you can see the area of zonular dialysis there up to 4 clock hours. But the cataract density is relatively just NS2 grade here. So we're planning for a phacoemulsification. As you all know, in these cases, the first key is to have a good rhexis and a slightly smaller rhexis. Because in case you have a rupture, you can always plan for a IOL in the sulcus or even an optic capture. So getting the right rhexis is very important. The initial stages, I do some incision like this, a limbal-based incision rather than a pure clear corneal incision. Usually I use this in the harder I think somebody is doing the controls. Somebody's changing it. Okay. Yeah, sorry. Yeah. So this incision helps me in the harder cataracts because in case you have a nucleus tilting or something and you want to extend, a limbal incision is better and safer to extend than a pure clear corneal incision. So that is why this incision. Doing a gentle hydro, as you can see the movement of the lens is there. So just make sure we want a good separation. Phaco technique, I would always say whatever choice is comfortable for the surgeon. So there is no hard and fast rule. You can do the stop and chop technique. Only thing, make sure the power is good enough. Don't use subminimal power, because when you have subminimal power, you start pushing the nucleus. And then either stop and chop or the direct chop method. So the key here is again staying in the center. And then don't withdraw your phaco probe, because here also zonules are already given way in some places. So that time when you take out the phaco probe, the AC collapses, and whatever intact anterior hyaloid face is going to be, then it can rupture and cause the vitreous to prolapse. So here again, make sure you use viscoelastic. And then cortical aspiration also, just minor changes, like something I call it as a cortical stripping then rather than aspiration. As you can see, just holding the anterior capsular fibers there, just strip it to the center. You don't have to be in a hurry in these cases because the adjacent zonules can break in these cases. So that is where you should be careful. You should not extend the zonular dialysis. So then using the CTR, as I said, the first case I'm going to show the CTR, the second case the segmental ring. So the CTR also, there are different methods of delivering it. I usually use the Sinski at the eyelet and just push it inside, or you can use forceps and 2 instruments to have the CTR in place. and then the IOL insertion into the bag. As you can see, this is only a minimal zonal dialysis case, and the incomplete coloboma, it is not a complete iris coloboma. So just placing and nudging the lens. Other thing is, when you do this thing, I don't dial the lens like how I do in normal cases. You just nudge the lenses inside. So these are some of the problems that we might face during the surgery, and we should be prepared for it. So now moving on to the second scenario, we also have the other design like the CTR rings and the Ahmed valve segment. So in this particular case, I'm going to show you some article published about how vitrectomy assisted phacoemulsification in these cases and why is it done. Because most of the times when we have a ZD case, when you're doing phacoemulsification, some amount of the saline goes back and hydrates the vitreous, and then the vitreous actually moves forward, and that is the reason during sometimes in the middle of the surgery you find that the AC is collapsing and everything, that iris starts to shrink, or the iris tries to come out through the section. So what they have published here, the Agarwal group, is doing a pars plana vitrectomy just to slightly debulk. So here again you see a case of iris coloboma, slightly larger than the first case. So here again getting the rexis right. Slightly smaller rexis, as you can see, this is what I was telling, the wrinkling of the anterior capsule where the zonules are not there. So here we are additionally using a capsular hook. So these are flatter and they give you some amount of support when you're doing the phacoemulsification. So you can see the difference between the iris hooks that is used and the capsular hooks. So here we are using the 23 gauge trocar. I think all anterior segment surgeons can use the trocar nowadays because we have a lot of wet labs done also by sir, and I think everybody should be knowing how to do a pars plana vitrectomy. So the whole aim here is, once you do a pars plana vitrectomy, and all phaco machines have a 23 gauge and 25 gauge vitrectomy compatible thing. So it debulks the vitreous, so you have more space, and then the anterior chamber is also more formed, and the whole problem of the iris prolapsing doesn't happen. So as you can see, again phacoemulsification being performed. So here we are using the coaxial method, but then the principles all remain the same. So here again, just releasing the capsular hooks, inserting the CTR. So here we are using the forceps actually. So that's why I said you can, you should know all the types of how it can be done, because sometimes these can slip and go inside. So always the second hand proficiency is very important in the left hand in these types of cases, whether you're introducing viscoelastic. And in this particular case, we did the 3-piece IOL into the bag. So ideally, when you plan for these cases, I always say we should always have a backup of a 3-piece lens, an iris claw lens also, so that you're always prepared for anything. So as how important a preoperative evaluation is, make sure you have the vitrectomy cutter, make sure you have the backup lenses when you have these cases. Since it was a larger coloboma in this case, we went ahead and did the single pass 4th row pupilloplasty, as you can see. It's a relatively very easy and a simple procedure and gives very good results. So, and this is how the case ended. So next, moving on to the third case, where we'll show you how to fix the CTS, the segments. So in this particular case, we are introducing the CTR initially. So then there are again debates about when to introduce the CTR. So it is like it has to be as early as possible and at late as it is needed. So you should know in some cases where you have to do it primarily. The only difficulty is you might have during aspiration of the cortex. But then there is another method when you do aspiration of the cortex in those cases is what they say is, instead of holding it and bring it straight forward, you go tangentially. So that helps in cortical removal when you place a CTR first and then try to remove the cortex. So here we are doing a flap. So basically after putting the IOL, we are going to fix the CTS segment here. So using the 9-proline needle and getting it, the one end of the straight arm needle is brought out. The second one is brought out through the main incision and then threaded into that eyelet which is there in the CTS segment. So you can see here, it is just threaded inside. So then using the raid roll technique, the second needle is also brought out. Now the segment is pushed inside at the area where it has to be fixed in the bag. So once it's placed into position, just tighten this and this fixes the bag in this particular segment. And this is how the case ended. So the last scenario is when you have a gross subluxation like this, more than almost the entire lens is subluxated. So here the plan should be always like a lensectomy, a vitrectomy, and a secondary IOL. The secondary IOL choice, you have a lot of choices. You have the claw lens, you have the MRNA lens, the glued IOL lens. So in this particular case, I'm going to show you one of my innovations, the CMT Flex IOL. So the first thing is we make two flaps 180 degrees apart. So this is important and key step for any secondary IOL procedure. And then 1.5 millimeters away from the limbus, we make a sclerostomy. So here doing something different, I'm not going to make extra sclerostomies. So since this is a soft cataract, I'm just using the needle to stabilize the globe here and a 23 gauge cutter through the other sclerostomy. So first just clearing some amount of the vitreous that is there. And then posteriorly, I'm making a punch and then going inside and with high speed and high vacuum doing the entire lensectomy. So the only thing is we should make sure none of the fragments fall inside. And in this particular case, it all worked out well since it was a softer cataract, as you can see. Just the right settings and just staying in the center, not without any too much of movements. Yeah, so once the lensectomy was done, so this is the new lens that I was talking about that I invented, that the CMT Flex lens with specialized T-shaped haptics that are there. So these T-shaped haptics, when you bring it out of the sclerostomy, opens up and just stays in position. So you don't have to do any tucking or suturing. So we have specialized Prenu T-Flex forceps that you can see has this broad tip. And this can be done through a clear corneal incision because it is a foldable lens, isn't it? So once you see the T-shaped haptic coming out first, you can either hold the head or the neck of the, now actually in this particular video, you're holding the neck of the lens. And then don't pull it out right now. So then inject, because it's a single piece lens, no? So you just inject the remaining of the lens inside from the cartridge. And once the trailing haptic is left over the iris or the section, and then you pull it out. So because of the special design, when it comes out, the T shape actually opens up with a pop and then stays there at the sclerostomy site. As you can see there. Just a small animation clip that it can be done through any normal foldable lens cartridge. There's no special this thing, and since it's clear corneal, it can be done at a different site when you have a complication in a small incision cataract surgery or any other complication. So you can use a different site or combine it with a trab or whatever. The second side, we're using the handshake technique here. You're seeing transferring the haptic, holding the arm of the IOL, holding it head on, and then bringing it at the other side. There'll be a slight tug at the sclerostomy side, but then by practice, I think every procedure has a short learning curve. You can see both ends that are there. So because of the marking, it just stays there. There's nothing else you have to do. So you just hydrate the wounds and then close it with either fibrin glue, or it is not necessary. You can also use sutures and also use the cautery. Because of the thickness of the haptics, there won't be any leakage, so it is not necessary to glue. So these are some of the post-operative day 1 pictures. And this is the 1 month picture, and we also have studies on UBM and OCT, which is going to be published, and about the long-term efficacy and safety. It's almost been 5 years now, and because of COVID, there was a delay in the entire process. So that's it.
Thank you,
Nivin. Thank you, sir.
So this lens is that is innovation of Nivin, and this is really very useful and comparatively very easy to other shake it and taking of glued IOL. We are also doing it and it is available now. So thank you, Naveen.
Thank you, sir.
Naveen is a very vitreoretinal surgeon and an anterior segment surgeon both. So he has the luxury of doing this partner vitrectomy, etc. Now we are inviting another our innovator, Rajendra Prasad. You must have heard his heart nucleus management. Now he is going to show you swing machine capsulotomy. So he has many innovations in his name. So this is something different you will find. Normally all of us are doing capsulotomy by different ways in hypermature cataract. Simple cataract, no problem. You can do any type of capsulotomy. In hypermature, there are many techniques. We all must be trying some different techniques, double capsular X-rays, or several things. So he has devised something which is very commonly otherwise we are doing. But he has devised something which is easily available and we can do it conveniently. Rajendra Prasad.
Good morning, friends, ladies and gentlemen. Thank you, Dr. SATANSHU Mathur, for the nice words, and I thank you for keeping me in this beautiful IC. The talk is on saving needle microcapsulotomy. So we do not have any financial interest in the subject matter of this presentation. We all come across these intumescent pearly white cataract, and they generally present to us in a different form. It could be intumescent soft immature white cataract, where you have a hyperhydrated fluffy cortex. You may come across with intumescent mature white cataract, where you have a swollen flocculent cortex with very voluminous soft nucleus. It could be intumescent hypermature white cataract, where you have a partial cortical liquefaction. It could be intumescent extremely hypermature white cataract, which is also called as a Morgaginian cataract with total cortical liquefaction. So how to differentiate them? You can use OCT. The OCT images can differentiate the type of the cataract. And secondly, you can find out in these immature hyperhydrated cataract, you can find out the fluid pockets, where the fluid pockets are there in the cortex. And we all know that all of these cataracts, they have a similar character, that is thin fragile capsular bag. And secondly, they all have a very high intralenticular pressure. So what happens when you puncture these white cataracts with a needle, when we use the 26 gauge needle or the capsular access forceps, you would see a volcanic eruption of the fluid which comes out from the capsular bag. This is primarily because there is a high pressure in the capsular bag, and there is a fluid filled capsular bag because of the pressure, and this pressure releases from the point where you are puncturing it, and the fluid comes out from that point. But this does not happen always, because many times what happens when you puncture, you could see that with the release of the pressure and the fluid, the capsular puncture which you have created on the capsule, on the anterior capsule, starts extending to the periphery, and it transforms in this kind of radial complete tear in the anterior capsule. So this is commonly, we all come across this situation. And this has been described as Argentinian flag sign by Perona in somewhere in 2000, year 2000. He said that it's primarily because of the raised intralenticular pressure and release of the pressure, which creates this extension of the capsular tear. So this used to be one of the very common complication, and most of the common complication in intumescent white cataracts. The percentage of incidence is almost 28.3% of the cases would come across this problem. That is the reason, because of the complexity of this situation, many innovations have taken place. And we all have come across, and including this small needle aspiration technique, we all have been doing till now. But what happens with the small needle aspiration also, when there is an optimum intralenticular pressure, even with the small needle, the moment you puncture, the capsule starts extending to the periphery, even before you could aspirate the fluid from the intralenticular space. So what actually the presupposition is, like it's not only the intralenticular pressure, there has to be some other reason also for the extension of the capsular tear. So we actually published this technique, saving needle microcapsulotomy, and we have given some physics about this, and the reason for that we found was, it's not only the intralenticular pressure, it is the configuration of the tear what you make on the anterior capsule. So what device you are using to puncture the anterior capsule before you start the capsular access, whether you're using the needle or capsular access forceps or something else. So what we have seen actually, when you're using the capsular access forceps or the needle, you puncture the anterior capsule, you are actually creating a cut on the anterior capsule. So this is a linear cut on the anterior capsule. And similarly, when you use the capsular access forceps, we tear the capsule before we start the capsular access. So similar kind of cut you make on the anterior capsule, then we start the capsular access. So what happens if you create a cut on the anterior capsule? This has a more proficiency to extend to the periphery because it's a cut. And if you have a pressure inside, the cut will easily open up. And this, what happens because of the pressure, when you make a cut on the anterior capsule, this cut opens up, the two edges of the cut opens up and extend to the periphery. So this actually is the reason why you get the Argentinian flag sign. So we had a hypothesis that instead of making a cut on the anterior capsule of this kind, why not to make a hole before we start the capsular axis? So what we did, we devised a device. This is a device. This is called the swaying needle microcapsulotomy. And you can see the tip of this device is round and pointed. It's not unlike the needle, which is a sharp tip, which has a sharp edge like a knife. So when you puncture the anterior capsule with this device, you will make a hole on the anterior capsule. Unlike when you use this, we'll make a cut on the anterior capsule. See, you can see the difference between the configuration of the puncture we make on the anterior capsule. One is hole and one is cut. The cut will open up, the hole will have a more resistance against any kind of pressure which is there in the interlenticular space. So this hole will never extend to the periphery. It will release the pressure in the capsular bag, and when you release the capsule pressure, then your capsule will decompress, it will become flat, and then you can start the capsular axis. So this is what happens, like when you puncture with this device, you make a hole, and the hole will release the fluid and the pressure from the capsular bag, and your capsular bag is decompressed, then you can start the capsular axis. So I'll go to you can make one puncture or you can make multiple puncture also, but the multiple puncture, when you make the multiple puncture, it has to be within the 5 millimeter zone. You don't make it beyond the 5 millimeter zone. Many times you have a multiple fluid pockets in these cataract, so you can just find out the pockets with the OCT, and then you can puncture these points to release the pressure. And to start the technique, you have to fill the anterior chamber with good viscoelastic, stain the capsule, and then this is the device. And this device, how to use this device is important. And you'll see the next, because when you go inside, you have to keep it vertically positioned and puncture the anterior capsule. And the fluid, you can automatically comes out, and many times you have to milk it out, like you have to use the visco cannula to milk it out, because the peripheral fluid, you have to bring it to the center, and that fluid will come out from the capsular bag, out of the capsular bag. So these are the multiple situation where you puncture the anterior capsule and you release the fluid like this. And once you complete the decompression of the fluid, this is how you have to milk it out. The fluid in the periphery will come out, and then you fill up the anterior chamber again with the viscoelastic, and then make a cut from that puncture. Now you don't have to worry, because now your capsular bag is completely decompressed and the capsule is flat, and you can very safely start whatever size you wish to make a capsular axis of this particular case. So to conclude, this is a very simple device, because just 1 rupee sieving needle, you can bend the tip and you can use directly. That also can be done, or you can take this device is available with Epsilon, and you can use this device for puncturing the anterior capsule. So it's very highly effective. This technique has been awarded the best film at the ASCRS this year, and one of the best technique was declared. Thank you very much, friends.
Thank you. Thank you, Rajinder. So we have many innovators here in present this session. So Saurav, now we have Deepak Magur with us. We all must have seen his videos. He's the best teacher. I am also following him on the YouTube. So many videos on all the cataract surgeries are available on YouTube by his name. So he will be showing today. We have seen already the glued eye, we have seen the CT lens, and now we are going to see the iris fixated lens. He has made so simplified this iris fixated lens that we can go and start doing surgery at our center. CT flex lens, what Dr. Navin has shown you, is available in the market without any financial interest. It is available with you should know where it is available with the Appaswamy Associates. Where your student is available here? Is the market available?
Epsilon is marketing
it.
And,
so without any interest, but we are showing something, you should know where to purchase these things. So it is with Epsilon, this needle. Maybe a little much. Yes, Saurav.
Good morning, friends. Thank you, Mathur sir, for this opportunity. It's a pleasure to be in your session. I'll be speaking of something which is much more simpler than any other options which we have for the secondary IOL implantation. And this can be practiced, or these techniques can be employed by most cataract surgeons. I think So I have been a very late entrant into this practice because I was using iris claw lens maybe 3-4 years back so much, but of late I'm using and I'm quite impressed by its safety profile and the ease of use and the quickness of the surgery. So whatever I've learned over the last couple of years, I'm going to share those tips and tricks with you for the use of iris claw lens. Now, this is a young patient. He's around 35 years old. He has a gross subluxated lens and also microspirophakia. I don't find any much advantage in trying to save the bag and fix the bag. In this case, I'm decided to do an iris fixated lens. I'm going to sacrifice the bag. Point to note here is, please note the paracentesis incision which we are making. We have marked it 180 degrees apart, and they have to be as short as possible. That's one of the secrets which you need to learn. We don't want a long corneal valve, and just visco expression of this lens is going to bring it out. We don't want to use any vectis in the dialer because vitreous is already there. So we don't want to introduce any instrument which is going to pull and tug, which is going to induce traction of the vitreous base, and that can cause retinal problems, giant retinal tears. So be as automatic as possible in expressing the nucleus. Then obviously the next step would be to take care of the vitreous which is there in the antechamber. So diluted triamcinolone acetate is a great tool for us to identify this vitreous and take care of it. It's just a matter of few minutes, then you'll know that when the vitreous is totally clear of. I'm going to use diluted pilocarpine here. We don't want a very small pupil, mid-dilated pupil. Then important to do a peripheral iridectomy. I've done using an vitrector here. So now the iris claw lens is being introduced into the eye. So first we position it so that the notches which are there, they are aligned at the our side port incision which you have planned initially. So the forceps which I prefer to use nowadays is, this is the Clayman forceps. Actually, it has got this small teeth. The advantage with this is it's very thin profile. So what happens when you're using in a post-vitrectomized eye, the eye is very soft. So you have a lot of corneal folds which disturb the visualization. So you don't want to create excessive opening of the incision. So just hold it. The position of the hooks of this forceps have to be aligned in such a way that they are just in line with the notches, so that when the notches go inside the iris, we know exactly where the notches are, so that we can press the iris so that the enclavation can happen. So this is one trick which I would like to share with you, because now you don't know where the notch is, because looking at the position of this claw which is there of the forceps, we know. And this I picked up from Dr. M.S. Ravindra, to use a blunt cannula rather than a Sinskuk. It prevents the making a hole in the iris. So just a small nudge posteriorly, you see a knuckle developing there once the enclavation happens. I usually do a couple of more times so that you have a knuckle, and we want to ensure that it is truly enclaved. So I'm just trying to nudge it around, move it around, so that ensuring that it is truly there. So now I'm not worried that the lens is going to drop down when I'm trying to attempt the fixation of the second notch here. So again, the eye chamber is refilled with OVD. Again, the instruments are switched. Again, the position of the forceps is such that it is in alignment with the notch which is there. The haptic goes underneath the iris, and then we are going to use this again 26G cannula to go ahead and nudge the iris there, so that you can see the knuckle developing. That ensures that the iris is very safely enclaved into the thing. So you'll have some amount of ovalization, but if you can enclave in the mid-periphery, you don't see that horizontal cat's eye pupil or the horizontal ovalization. So that's the trick. You have to enclave in the mid-periphery. So this is another case of a hypermature phacolytic Morgagnian cataract with extremely loose zonules. So this is a planned manual small incision cataract surgery in this elderly patient. Again, you can see long-standing inflammation is there. You have to resort to any of the techniques of your choice for doing this. Initially, my attempt was to try to save the bag. So I'm trying to puncture the anterior capsule and try to see whether I can save the bag by putting any ring or anything. But immediately I could realize that it was not going to stay there. So once the nucleus is expressed out, the bag is there, and some of the lens matter is also trickling down the soft cortex, liquefied cortex. So obviously there is no bag which can support this. So you're going to do the antivitrectomy, and one of the most commonly asked question is, can we manage any of these cases without doing an anti-vitrectomy? The most complications which happen because of any lens, whether AC lens or iris claw lens, is because you're not managed the vitreous well. So managing the vitreous well is probably the most important message which I'd like to. This is again using a vitrector to just do a small iridectomy in the periphery. The pupil should be ideally mid-dilated. It should not be too small, maybe around 4 millimeter, 5 millimeter. And again, I'm form the chamber with viscoelastic so that again, as I told in vitrectomized eye, the eye is very soft. The moment you go inside, there'll be corneal folds. And that will, so again, the position of the forceps, this is a different forceps. This is the traditional iris claw lens forceps, the broader plate which we have. Look at the alignment where I'm holding. This ensures that, I can now visualize under the iris where the claw is actually. So you're introducing it again, and once you're underneath, one the haptic is underneath, the haptic is pushed against the iris, so the iris comes up. So you know where your side port incisions are. Best would be to always mark it initially. You don't want to struggle and see whether it is where the side port is. Then just go it and then press the iris down. You can see the knuckle there. And then, as I said, you try to again move the lens a little bit so that you see that the iris is also moving along with it. That ensures that your enclavation is foolproof and you're not going to drop the lens back. So that is one of the major concerns for all the beginners, that how do I know that the enclavation is done properly or not, and I may drop the lens. So this is one small trick. Again, holding the lens at that position ensures that mentally you can still visualize where the notch is possibly there. So just beside where it is, you can just do a notch so that the haptic slips and the iris goes in between and enclaves. Again, you just move and see that both the iris ends are enclaved properly. So in these eyes, we want to go and remove the OVD. The eye is very soft. You can't go through the side port. So in this case, as you see, I can going through the main port itself just to clear off the OVD and some of the remaining vitreous. So the 3 tips which I'd like to share with you is, which I have learned from many of my colleagues, seniors, to make a small, short the side port incisions, to mark it and make it. That is, I learned it from Dr. Ravijit Singh. And you just have to make it as short as possible. You don't want a long tunnel. So long tunnel, you can't reach the area where you want to enclavate. Use the appropriate forceps which has got the thinnest profile. That is very important because we don't want excessive corneal folds which hamper the visualization. And align the forceps in such a way that the tip of is matching the notches in the haptic. So then use a blunt instrument to go ahead and tuck it. That should be it. And it gives us reasonably good results with very less complications and a very quick procedure. So that was it. Thank you for your attention, and thank you.
Thank you very much, Dr. Deepak, for the beautiful technique and beautiful videos for how to use these iris claw lenses. Because these lenses have become now the choice of surgery when you have to treat the aphakia, where you are not able to put the IOL in the bag or out of the bag. So you have seen a beautiful technique. Dr. Mathur, when you are putting these lenses, what should be the size of the pupil? But after the surgery, after removal of the cataract, do you dilate the pupil or constrict the pupil?
No, I constrict the pupil using diluted pilocarpine. So usually when cataract surgery is done, the pupil is very well dilated. Once you do vitrectomy, so we want the pupil to be somewhere around 4 millimeter, not too small, not too big. So that's the reason I don't use undiluted pilocarpine. I just use a diluted pilocarpine so that it just comes. So
you're looking for what size of the pupil?
4 millimeter should be
4 millimeter should be the ideal size. Yeah.
So I don't want 2 millimeter. I don't want 6 millimeter.
All right.
So somewhere in between. 4 millimeter is what I'm aiming at. So just use 0.1 or 0.2 ml of diluted intracameral pilocarpine to achieve that.
Right. And what should be the post-operative management in these cases?
Nothing what dramatically different.
Any difference?
Same. Nothing.
No, you use hometropine also in these cases?
Not much. If the case is a complicated case, we have before only. You're dealing with a phacolytic glaucoma which has had an inflammation for some time, then maybe you can use anything. Not anything specific to this lens as such.
All right.
But pressures and inflammation are to be monitored regularly, and case by case you can do it.
Right,
and you have to do an iridectomy. Don't forget about that. Good vitrectomy and iridectomy are the key to success in these patients.
Thank you very much.
One more thing, if you want to start this technique and you are afraid of dropping the IOL, What I have done, because we have learned this technique from guru of this technique, that is Dr. Daljit Singh sir.
Dr. Daljit Singh.
But we have stopped doing between because we are not sure. But again, we have started doing this. Seeing the circumfixated lens is not so easy to implant by everyone. You can do in normal case. We have done this starting the camp normal case where the posterior capsule was intact. Instead of doing PCIL, we have done this iris flow lens because we were not afraid if you drop it will go somewhere because the capsule was there. So to be start, you can do in the normal case. So once you are sure of after 2 or 3 cases, then you can go with the without capsule support.
So this is the simplest of technique, I think, to manage that.
So now we introduce
now I'll call upon Dr. Kamal Bandhu Kapoor. Dr. Kapoor, you know that he's one of the big name in cataract surgery. He's practicing in Delhi and he's the CEO of Sharp Sight Centers all over India. And Dr. Kamal is going to talk on capsular axis extended, what to do.
He's also another innovator in our camp here.
Thank you, Dr. SATANSHU. Thank you, Doctor. Good morning. I'm sorry I'm a bit late. I got hurt, so I just took a little bit of physiotherapy and I'm here. So I'll be talking about the anterior capsule. Most of the times we are taught, what are we fairing? We are fairing the posterior capsule or we are fairing the endothelium. But anterior capsule needs to be faired too. So we will just see some situations where actually the anterior capsule has its tantrums like a young kid and how to manage that. So we will be seeing some helpful tips. So before we go anywhere, we need to see what all can happen. You could have your keratome penetrate the anterior capsule. You could have an intermittent capsule cataract with a small pupil capsule running out. While doing rexes, you could have a subincisional runout, which is pretty difficult to manage. You could have a subincisional runout in an intumescent cataract. You could be doing a femto cataract and you could be having a runout to the intumescent cataract. So we'll be seeing beautiful videos. I've got more than 42 small videos for you for whatever you can think of in anterior capsule. So some basic principles you need to understand first. The thickest part of the capsule is anything between 5 to 9 millimeters. So that's why you restrict your rexes between 5.5 and 7.8. Don't go beyond that. But the moment you start going beyond 7.5 millimeters, another problem starts. That's where the zonules are inserting. So if your capsule hits a zonule, the zonule by its inherent nature will try and pull the capsule out if you do not have enough anterior chamber pressure. So what you need to do is you need to relax your zonules anteriorly. So if you relax your zonules anteriorly, they will not pull the rexes out. So once you've understood this, now I'll get into the physics. This is actually how the anterior capsule is and posterior capsule is pulled by the zonules. And this is the zone where you should be restricting your capsule rexes. Now you need to balance the pressure, the intralenticular pressure and the vitreous pressure into the anterior chamber. The anterior chamber pressure has to be higher than them, only then the anterior capsule will be flattened. If you have a flattened anterior capsule, which means your anterior zonules are relaxed, so you're in a safe zone. So there is a play of physics here. The centrifugal and the centripetal forces are working it. Centripetal is the force which is pulling inwards and centrifugal is the zonule pulling it outwards. You need to have more of centripetal forces to have a smaller rexes, and you need to have more of centrifugal forces, then the rexes will start going out. I hope you understood this. Now we go to the next level. What happens and why does the rexes go out? Number one, if you're touching the zonules and the zonules have more pressure, which means that anterior chamber pressure is less. Number two, while doing the rexes, you're so focused on the rexes, your wound is leaking, viscoelastic is coming out. At some point, you go near a zonule, visco comes out, rexes runs out. We'll see beautiful videos of that. Hypermature cataract, you flatten the anterior capsule, you started the surgery, but the intralenticular pressure is very high. So whenever this fluid leaks out, there's a sudden burst of change of pressure between the intralenticular pressure and the anterior chamber, and that has an explosive effect, and you have an Argentinian flag side. So once you've understood that, I'll just demonstrate what happens. This is what a capsule is in a cut section, what is happening. As you're pulling in, suppose the pressure in the vitreous or the lens is higher, the lens complex starts moving up. So once it moves up, the anterior zonule is pulled. So this is what happens when the visco leaks, and this pulls your capsular rexes out. So I'll be showing a technique which I've developed, and it's in publication for Journal of Cataract Refractive Surgery. Now this is most feared thing, making sure there's no run out. This is an intumescent cataract, totally turgid, there's fluid in. So I take a 26 gauge bend needle, I bend it backwards, bevel down, I go at the junction of the inner 2/3 and outer 1/3, one fast jab and start aspirating. Don't wait. Go in and start aspirating. The syringe should have some water in it. It should not be pure air because you will not be able to create the vacuum. And once I've reduced the pressure, so we have a straight linear line there. Now I enlarge my wound because initial wound is small because I don't want the visco to come out suddenly. Once the wound is enlarged, I go in, I use a 1 hour, I create a linear cut. Now I have a T. Now this T has 2 flaps. In case one flap starts running out, I have another stepney. I can rotate the capsule rhexis from the other side. So I've made sure now I do a roll technique, which means I push more viscoelastic on the top because if there is any fluid collected behind the cataract, that should get compressed and come out. And now you start, and I'll just go fast forward. Now this is simple. So one, complete half, and then use the other hand to complete the other. The advantage is you can make any shape, any size with this technique. So I call it the T technique. Now in case you already started having a peripheral runout in intumescent cataract, what to do? Again, T technique to your rescue. Now this is an intumescent cataract. You can see the chamber is flattened, the pupil is pushed forward. I'm making it. This is one of my assistants, junior associate surgeons doing the surgery, and she's operating, and suddenly she sees a run out. I'm standing next. I said, okay, wait, I just take over. I push in viscoelastic. I use the same technique of reducing the interlenticular pressure. I push in viscoelastic. I'll just fast forward. Push in viscoelastic, flatten the interior chamber, and then again do the same thing. We'll skip it. Go into the lenticular space, suck out the fluid, reduce the pressure again. And once this is gone, the initial linear cut which is created by the needle is again converted to a T. Now we see a T. Converted, include the peripheral extension, and there you are. You saved the day. So this is the T technique. Now this is an interesting situation. Again, this is a recording from one of my surgeons. The peripheral extension has happened and the person is not following the simple diktat, flattening of the interior chamber. So we'll fast forward and see what happens. There's a lot of pushing, pulling happening. And there we'll jump in and see what has happened. We have a PC opening. There's a run out. So what could have been done, we'll see in the next video. If there's a peripheral extension, make sure relax, panic. Do not keep pulling at the tag. Push in viscoelastic, flatten it. Hold the capsule as near to the advancing edge as possible. And with one jerk, bang 90 degrees to the peripheral extension. One jerk, break it. Do not hesitate. There was so much of hesitation there. Pull, push, pull, push. Hold it, boom. So that's what happened. So now this is another interesting case. See, we'll see the same thing now. There's a peripheral extension, you'll see, holding near the edge, and one go and you just pull. So initially pull it to the center and then tangential and complete it. If there is hesitancy, you're gone. We'll be seeing very, very short videos now. Again, similar situation. So this is tricky. You're nearly subincisional. So use a scissors. Use a scissors. So I'll use a scissors and nip this part because I know if I try and pull this, I might actually go subincisional because the vectors can never be perfect in subincisional. When you're going to go hold under subincisional, you lift the anterior capsule up in the wound and the wound leaks. So you can never have a good pressure. Okay. This video I'll show you. Most of the times when you're so busy doing the capsule, you don't see the tag coming out of the wound. This tag will run your rhexis out. Never continue your capsule rhexis like that. Always a good idea to use viscoelastic from the opposite side, cut it from the side, pull it in and then continue. Thank you. I think I could just show you 9 videos out of 42. Thank you.
Thank you, Dr. Kamal, for the really good videos and beautiful videos.
Kamal, you know you have endless videos, but we do not have the endless time, unfortunately. We are still waiting for the Partha to come and join us for his talk. So really, these are the young, dynamic and most inspiring persons we have in our camp now. Yeah. So we have seen the capsule axis.
Yes, now we'll go on with the next talk is by Dr. SATANSHU MATHUR. He's the chief instructor of this session.
Hello.
Dr. Mathur, you all know he's practicing in Haldwani, and he's one of the very, very good cataract and refractive surgeon. And you must have seen him SST and DSTC and all, like he always holds all these SSTs in all the conferences, and a well-known person. So he's going to talk on IOL damaged, unhappy patient, IOL exchange made easy.
Thank you, Rajendra. We have seen the good capsulosis, how to manage the complication. We have seen PCR is there, how to manage the lenses. Now, even after that, if you put the lens inside, everything is good. Now, how to satisfy the unhappy patients? So, there are many indications for IOL exchange. Nowadays, a wrong IOL power calculation. Unhappy patient, especially the multifocal lens. What we are having following this patient having halos problem. They are creating havoc in the clinic. So we have to exchange even the good lens with passive vision. We have to exchange it because of the halos and other things. Dislocation of lens that was initially positioned but changed after later on. Poor positioning of the lens, there PCR, even then you have put the lens inside, lens is decentered. So these are damage to an IOL to haptic during the insertion. So these are the common things where we have to make. There are many techniques. You can apply any technique. We cannot show all technique in 5 minutes time. So if you want to enlarge incision, you do a SICS incision, 6 millimeter, you can explant the lens easily, no issue. But if you do not want to enlarge the incision, then we have limited options, and that is we are going to discuss today. So this is a case that came to me from the neighbor city. Patient was not happy because he was having +4 diopter spherical power, and for near he is to use 7 diopter. So in that city, nobody advised him to removal of the lens. Everybody advised us use the spectacles. Vision is good with the glasses. You should not get change. But patients are not satisfied nowadays with glasses with 4 diopter. Otherwise, was emmetropic. So I thought, if I do not remove, some other will remove it. So why can't we do it? 1 month before surgery, I used to see how good surgery was done by my friend in the neighbor city. I was really impressed by his surgery. But I motivate the patient. I make him understand surgery is very good. There may be some calculation mistake, but this is machine dependent. So don't worry about it. So things is this. So how we can expand? This is a simple technique. Because IOL was implanted recently, we can dislocate it easily outside the back. But we have to take care of 2 things only, posterior capsule and cornea. So we have to inject lot of viscoelastic during the surgery, should not allow chamber to collapse anytime. It was recently operated, so we could easily explant it into the anterior chamber. So once the lens is in the anterior chamber, it is managed by a simple forceps, cutting forceps, scissor. This is easily available, 5,000-6,000 rupees on all the stalls almost nowadays. So we should have this scissor in our OT. It is really very helpful many times. Though you don't want to use it, but it is your, you can say, ये आपकी मजबूरी है कि आपको ये निकालना ही पड़ेगा. So once this is simple scissor, we just cut not through and through. This hydrophilic lens, we have cut not up to the center, but up to the less than center. There are many techniques. If you remove this lens now, even it will come out. But to show you different techniques, I am just making one more incision. So we make a curve, triangle type curve, and we will fast forward. कैसे करें? So we are making another cut. So a triangle is cut here. Even I am saying, if you are doing one cutting, you can remove the lens easily. It will come out. But we have done one more cut, triangle, and now we are enlarging incision to 2.8 millimeter. So we can remove this lens from the same port, same size that we are doing the phaco. No need of any suture. So one part is removed. Now you rotate the lens. Just hold with a simple forceps. It should have serration inside it. hold it and pull it. At the site of the wound, it is acts as a fulcrum, and you can easily remove this lens from 2.8 mm incision. So this is a very simple technique, and you can manage it. So then I'm not going to show you the plant. So that is done by the second video. Channel. Other video. Channel. So the another video. This is OPC5 lens. We are nowadays seeing lot of cases in our OPD, operated by us and operated by our colleagues long time back. I don't know what about new lenses. They will OPC after 10 years. But this case was operated by my colleague somewhere. We don't know which lens it is. Almost 12 years back. Patient is less than 660 vision. So we have no choice but to remove it. And in this case, we were confident because patient was already not having vision. In the first case, patient was having 6/6 vision, so we were slightly worried during the removal. So lot of adhesions are there. So we have to be very cautious and very patient in these cases. Just inject scholastic behind the iris, below the lens, above the lens, and try to pull out the lens. Again, the same way, you have to be very patient. Yes, lens has come out into the chamber. Now you have other same, because we have our topic is on the scissor, so we are showing the same cases. Otherwise, there are many other techniques which we are using for this IOL removal. So again, we are enlarging the scissor to 2.8 millimeter, and this case we are putting a scaffold lens behind it because this lens is thick, so we don't want to scissor to injure the posterior capsule. We have injected the scaffold lens of the desired power behind the lens. Now we are sure that we are not going to damage the posterior capsule. Now we have to take care only the anterior capsule. So lens is already in the position, second lens. And now in this lens we have to hold the IOL because it is moving around and cutting the scissor. The other side port is just to hold the lens. So that is helping in cutting the lens. And then we have a small cut and we have removed. In the first case, we have made the two cuts, triangle move. In this case, directly by first cut, we are removing the lens because at the cutting edge is acting as the fulcrum at the side of the bone. We have removed the lens. So this thing is very easy. Theme difficult, but it is very easy and you can manage easily. Other lens is already in the position. Third video दिखा देना. This is another case. This is very common, especially with the Indian cartridges, that lens haptic of tip get broken. You see, this is a hydrophobic lens, and during insertion, the tip is broken at the edge. This tip is broken. So, so tip is broken. Sorry, haptic is broken. We cannot keep this lens there. Now, previously we were keeping the lens there because we were afraid of removing it. So whatever happened, we'll see later on. But your colleague is going to make a hell of you when you see the broken haptic. So you better to remove it nowadays. So in this hydrophobic lens, we have to cut through and through because this is a very hard lenses. So we have cut through and through, and then we can remove the lens one by one, the all pieces. So this is just cutting and then removing it. So there are many techniques to handle this case. I'm not will take more time. So because there are other speakers. So I want to emphasize only one thing. You can use any technique, but you should be familiar with the lens removal. Nowadays, it is you cannot keep the broken haptic, broken optic inside the IOL. Thank you very much. Now
Thank you, Dr. SATANSHU, for the beautiful videos and very beautiful techniques you have shown how to explant these IOLs. A very simple query, like when you are explanting the opacified IOL or the hydrophilic IOL or hydrophobic IOL, what difference you find?
He is also expert of this, removing the fluid.
So Deepak will answer this. Yeah.
Sir, it's actually very simple to remove a hydrophilic lens, but the hydrophobic lenses are much more thicker, much more tenacious, and they're much more difficult, especially the multi-piece lenses, like the MA60 AC or the Sensor multi-piece. They're very thick. The secret here again, you have to use good viscoelastic, and the scissors have to have serrations. I usually prefer to have a bimanual technique. The second instrument has to stabilize. Otherwise, if you just go and cut with any scissors, it's going to flip and jump.
Yes.
It's going to cause damage to the corneal endothelium as well as the hydrophobic lenses. The hydrophilic lenses are very soft. You cut, you don't cut, you can remove. Either way, it's fine. But hydrophobic lenses, you need to be very careful. Use good viscoelastic. Create space using a cohesive OVD so that your scissors don't damage the rhexis margin, the posterior capsule, and the endothelium. Stabilize the lens with the second instrument. Use the forceps. I prefer to use the Osher serrated forceps. That is inexpensive and does the job well. And second thing, sir.
Deepak, what about the opacified lenses?
Opacified lenses are usually hydrophilic lenses, what I have removed so far. But if the challenge here is, sir, if the lens is for quite some time, the elderly patient, saving the bag itself. Sometimes the bag and the haptics are so glued together, in the process of maneuvering the lens out, you may lose the bag. If you have such a situation, a long-standing case, just ampute the haptic, leave the haptic in the bag itself, remove the optic, put a multi-piece lens so that the remaining space of the bag is occupied by these lenses. So don't be overzealous in trying to remove the haptic, because that can disturb the bag.
So many times, because these opacified lenses are calcified also.
Yes,
so if they are calcified, then it will become very difficult to cut and remove. And the one very simple technique what you can add to this is when you are cutting the lens, one of the haptic, you pull it out of the wound. When you pull it out, hold the haptic out of the wound. That stabilizes the lens, and that will prevent the flipping of the lens also. So have you tried this?
Yes, sir. But only thing is, sometimes when you're holding it tight, the wound gets torn a little bit because of that. That's the one concern which I have.
All right.
Because of that. Otherwise, that's a good technique to really hold the lens.
Right. So you
can sit here.
So we'll go ahead with
you can sit here, chairs.
But they can't see well, I think.
We'll go ahead with the keynote address now, and our keynote address is going to be given by Dr. Prakash Kumar Chaudhary, and Dr. Prakash is from Bangladesh. He is a consultant ophthalmologist, phaco and LASIK surgeon, and he is a fellow of phaco surgery from India itself, and he's MSDO and MCPS, and he's going to talk on my worst case scenario.
Greetings from Bangladesh. Thanks to everyone. So I will share some unwanted experience during my phaco. This was a 50-year-old man having soft cataract with limbal dermoid in the right eye, and there is no history of ocular trauma, and there is no significant astigmatisms, and the left eye is normal, and we plan for cataracts phaco with under topical anesthesia, and according to on the patient's demand is trifocal lens. So after making the 2.4 millimeter main ports, an optimum size rhexis is being created with a 26 gauge band hydrocannula. Then in the Akausia small band hydrocannula, the hydrodissection is being performed. And every time after injecting the fluids, the nucleus is decompressed. Now you can see there is a subluxations in the subincisional area which was missed during the preoperative period. So I go ahead for the sculpting, and note here my bottle height is very low, infusion flow is very low to avoid undue pressures on the capsular bag and to take care of the remaining zonules. And my corresponding aspiration flow also very low, only 18 cc, and vacuum also 18 millimeter mercury. And the sculpting is going on, and usually my preferred technique is a four quadrant nucleotomy, but to avoid undue pressure here I am doing the chip and flip techniques, and before take out my phaco probe I am injecting the dispersive body through the side port to maintain the stability of the chamber. My next plan is to put the CTR ring to stabilize the capsular bag, and And now I'm checking the presence of inhibitors to inject in the triamcinolone acetonides. I can see there is a bitters is there. So by swiping the bitters to the side port with the spatula, I proceed for educate vitrectomy with the high heart rate 4000s, and my inflow is very low, and corresponding also I have very low aspiration flow rate. And again, I'm injecting the dispersible to the side port before take out my irrigation handpiece, and then I proceed to remove the remaining nuclear materials. So with a very low inflow and low infusion pressure, I am taken out by the remaining fragments. Now we can see the pupil size has come down, and this is the time. So I am injecting the cohesive OBD under the iris to lift up the iris margins. My plan is to use the iris hook over here so that I can see the cortex very clearly, and with the using the bimanual IA, I am removing my cortex. And the advantage of the bimanual IA, as the irrigation and aspiration handpiece are separate, they maintain the anterior chamber greatly. Again, I am injecting the dispersive OBD every time to maintain the stability of the anterior chamber, and according to patient's demand, I proceed to implant the trifocal IOL over here. And trifocal IOL is being injected. Now the iris hooks are removed, and one bite is taken, and the remaining, the OBD is removed to the bimanual eye. The case is over, and the side port is hydrated, and you can see this is the first postoperative day. The cornea is clear and everything is okay. Then the second case, so this was a small non-dilating rigid pupils. So injects intercameral mydriatis to improve the dilatation pupils. Now I am injecting the cohesive dispersive OBD followed by cohesive OBD, but the pupil is not dilating, which is a strong indications of the rigid pupils. So after AVIT, that is STS pupil opacity, I am using behexing over here as a pupil expansion device, and after injecting some, the behexing is placed in the anterior chamber above the iris, and after injecting the cohesive OBD under the iris, the behexing is tucked. They're using a 23 gauge forceps through the side ports. Now I chips a good circular, and here I am using the tip and blue to extend the vitreous. And the advantage of this technique is it does not allow the anterior chamber and pupil to get collapse, and optimum size rexis is being created with the 26 gauge band hydrocannula. Again, hydrodissection is I am performing. Usually I prefer Akahosia small band hydrocannula, and the advantage of this cannula, I can go up to the equator. And now the sculpting is proceeding, and with the again with the low bottle height, low infusion flow. Here I am using the Stoven chop technique to divide the nucleus into multiple fragments, and here also I am keeping my bottle height is very low, and phacoemulsification is complete with the routine using the torsional ultrasounds and uninterpreted burst modes. And I'm using the bimanual eye, and before taking out the handpiece, I'm injecting the cohesive OBD, because now my next plan is to implant the IOL. So during implant the IOL, during forward movement the IOL, you can see over here there is a fracture between, and the optic is fractured between the mechanical obstruction. So to exchange this, I first inject the dispersive OBD above and below the IOL to take care of endothelium capsules and posterior capsules, and I'm cutting the lens into the 3 pieces, holding the lens firmly with the left hands, and through and through I cut the lens into 3 pieces. Then each 3 pieces is taken out very gently through the main port, as you have seen earlier in the earlier presenters. And after being that, a new IOL is being implanted, and behexing is disengaged and taken out to the main ports. In this case, this was a routine cataract, and after making side port, the dispersive OBD is being injected, followed by cohesive OBD, and ideal soft shell technique. Again, optimum size excision is being performed, hydrodissection is being done, and the nucleus is managed. I'm dealing with the nucleus. Here I'm using the S2 chop technique, and nucleus is removed in a routine way. And if nucleus is taken out, at this point I noticed there is a resistor at the 6 o'clock, but when and how this resistor occurs, I could not figure out. So I inject dispersive OBD through the side port to maintain the stability of the anterior chamber, to prevent so that the tear cannot extend further. And with a very low bottle height, low infusion flow, and low vacuum and low aspiration flow rate, I am aspirating the remaining cortex by manual IA. Here my bottle height is only 60 centimeters. And now you can see there is a PC tear through and through oriented in the same plane. And so now I have rexis tear and at the same time PC tear. So before taking out, I am injecting the dispersive OBD through the side port before take out my irrigation handpiece. Now what will be the next plan? Should I implant a single piece IOL in the back? If I can do that, it will be more tricky, physiological, but by doing that, I may extend the PCRAN and I cannot get enough support to place the IOL in the back. Another option I have, there is a multi-piece IOL in the sulcus, which is a bit easy solution for me. So I decided to implant the single piece IOL into the back. So before unfolding, I rotate the lens and I place the lens in the anterior chamber cautiously. I didn't put it in the back. Then through the side port with the dialer, I put the haptics first into the back, and through the other side, again the same technique, same principle, I am pushing the another haptics into the back. You see the IOL looks in good positions, and I inject the pilocarpins to constrict the pupils and inject triamcinolone acetonides to see the presence of any bitters. The bitters face was intact, there is no disturbance of bitters. So anterior chamber is washed with the BSS. Pupil looks, everything looks okay, and external main port and side port is being hydrated. And this is the first POD. The intraocular pressure was 14 millimeter mercury and cornea is very clear. Thank you so much for watching this video.
Thank you, sir. Thank you. So you have seen this again, the use of Caesar, you have to expand the lens, which is very common, not so uncommon like before days. So we have to be very aware of managing the complications, and we should have all types, especially sulcus fixated lenses we should have in our OT, because there is a PCR, you cannot fix the single piece lens. We should avoid it, but we are doing it because we are not having single piece lens, 3-piece lenses. So now we have none other than Dr. Partha Vishwas, Chairman Scientific Committee. So we welcome him, and he is speaking on a very important topic, PCR. All is not lost. Still we have many ways to manage it. Partha.
Thank you very much, sir. And first and foremost, before even I say good morning, I have to apologize to you, all of you, and especially to our chief instructor, for whose I see people have to stand. I feel absolutely saddened and belittled because I could not provide a bigger hall than this. The hall actually was supposed to be twice as this, and but unfortunately we had to make space for the preview room, and that's the preview room that has taken up half the space. So I really apologize, and I'm really sorry about this. However, this is a course that goes on, and Dr. Mathur's course is full of wonderful tips, and we learn from each other through these tips. PCR and something that, you know, when it falls through, then what do we do? Now, when it comes to PCR, the first question when a PCR has occurred, we have to answer is whether I can do a PCC, whether I can fashion it into a posterior capsular rhexis or not. If I can fashion the PCR, the ruptured PC, into a rhexis, then the whole management is different, the lens implantation is different. But if I cannot do that, then everything is again different. Now, let us see in this case, there's a large PCR that I have that has occurred. and the nucleus and cortex, a huge chunk is there. Here, of course, it's impossible to convert it into a PCC. So what first I have to do is to compartmentalize this chamber so that the viscoelastic is in between the large nucleus and the cortex, and the PC is down below. And with very, very low parameters, you can take away the nucleus and the cortex very smoothly. Please remember, the moment you feel that vitreous is there, please remove, put in a little more additional viscoelastic, stain, do anterior vitrectomy, all vitreous out of the way. Then again, you can go ahead and take off wisps of cortical matter if necessary. Here in this case, vitreous has not shown, so we are able to take off the little bit of cortical matter, and you can see that there is. However, please do not rely upon your naked eyes or the microscope that you're using. You have to use triamcinolone. And in this case, we are placing a 3-piece IOL in the sulcus. And you can see that these eyes, you have to be very sure that both the haptics have gone into the sulcus, and then you go ahead and capture it and place in triamcinolone. If there is any amount of vitreous, please do anterior vitrectomy and then only close the case. So triamcinolone works in two ways. It shows you, yes, there's a vitreous tag, or no, there's no vitreous tag. The other thing is, next day, the cornea is much, much more better than if you have not used triamcinolone in the anterior chamber. So definitely to use triamcinolone. Now, a PCR with a central rupture, if there is a central rupture in this PCR, and you can see that everything has gone on well, and it's only at this last stage, maybe due to carelessness, maybe due to any inadvertent movement, a PCR has occurred. And with this PCR, what you need to do is, it's a small one, you need to fill it optimally with viscoelastic, a little bit of cohesive viscoelastic first, and then with methyl cellulose, and then taking the microforceps and making a posterior capsular rhexis out of this. So if there is this neat posterior capsular rhexis, then the whole management is different. You can put in bulky lenses as big as this inside the bag, and that should not have a problem at all. And because this is a stable capsule, and with a stable capsule as this, lens is not going to hurt the capsular bag in any way. But of course, you need to be sure that there is no anterior vitreous. Now again, this is again a large PCR that is there, and with this large PCR, if the nucleus can be removed, it's important to remove as much as possible. And again, suffice it to say that the amount of cortical matter also can be removed extremely well. It is important again to see that the methyl cellulose is being placed every time this goes on, and the bag is nice and stable. Not to remove the phaco needle, of course, while the methyl cellulose gets filled up into the bag, and then only gradual assessment of the posterior capsular rupture has to be made, how much of it is gone, and then going ahead to placing the intraocular lens. So basically, at times where everything is more or less in stable condition, the multi-piece lens is the lens that every lens that you have to implant, whether they be in a multi-piece or a single-piece lens, please have a backup lens. A single-piece lens definitely should have a backup lens. Please have in your library a backup lens, which you can use maybe in the rarest of conditions, but this lens is a very important lens and needs to be used as and when necessary when there is a PCR. Now, a very controversial topic, and I'm going to dwell on this topic, trifocal IOL in PCR. Yes or no? Maybe have a quick show of hands. Trifocal IOL in a PCR, yes or no? Would you or would you not? Niyaz sir. Satanshu sir. Nevian. Okay, yes. So the question is yes, and the question is no as well. So when yes and when no depends upon what is the situation. If the situation is this, that there is the first eye has already had a trifocal and this is the second eye where you have done a PCR. So here is a situation where you can judiciously think of placing the trifocal in the bag if it is possible, but it has to go into the bag. If it cannot go into the bag, please do not put the trifocal. You will have to counsel this patient whether you put a trifocal in a PCR or whether you do not put a trifocal in a PCR and you have placed a single piece. Counseling is most important, and that's post-operative counseling and needs to be done. Now let's go on and see how it is to be done here. So we are placing this trifocal lens in a PCR that has occurred, and as Dr. Prakash also showed very nicely, so it is the folding of the haptic onto the optic that has to be done very well in the anterior chamber, landing it on the iris and never into the capsular bag with a ruptured PC. That is the first trick. The second trick is, again, once one haptic has gone into that place between the posterior capsule and the anterior capsule, then placing the second haptic, again knuckling it so that it just fits in. But of course, most important is the use of triamcinolone. Again, I'll dwell upon the situation where you are trying to put it in the bag and it does not go in. And you see it's sinking down. If it is sinking down, the first haptic, that's the leading haptic, is sinking down. That means what you have done is the bag, the ruptured bag has actually collapsed. And you'll never be able to separate that ruptured bag because vitreous has gone in and you'll not be able to get the vitreous out of the way. So these are situations which are very, very judicious. If you have separated the torn posterior capsule from the anterior capsule, you have that space and you can place the leading haptic in. That's the first thing. If it has gone in, fine, go ahead with the trailing haptic. But if it has not gone in, please take out that lens and replace it with a three-piece lens. Okay, so this is another patient with a PCR, and we have this is a toric lens. Again, with a toric lens, if the rupture has occurred in the toricity, then it is a very difficult proposition. But if it has not, then it is easier. So in this, I was to put a toric lens. I could make a PCC and then place the toric lens in position, and that can be done. So if again a toric lens has to be placed, it has to be placed in position only if you have carved out a PCC or the rupture is 90 degrees opposite the toric markings. So I'll go on to the last two videos of mine, and they are going to be similar to what Dr. Prakash also has shown, but I'm going to show you just one or two small tricks so that, but with this amount of thought that if it can be done well, if you think your expertise is good enough, please do it. But if you think that you're coming too close to the waterfall and things are not going well, just take the lens out and put a three-piece lens. So this is not for all cases again. So here no vitreous has come, we have a PC rupture, and you can see that's a large PC rupture there, like a hammock. But there we have opened out the posterior capsule from the anterior capsule, and now we are landing the leading haptic over the iris, very important, over the iris, and the iris should be nicely stretched out. If it's a small pupil, lesser than the rexis, you will not be. Now this is very important. I'm showing it very, very well, that knuckle has to be there, that knuckle, and then it should be just nudged in between the space of the posterior capsule ruptured and the anterior capsule. And again, see where the manipulator is, that's the exact position of the manipulator so that you're not traumatizing the posterior ruptured capsule anymore. So once this is done, so it goes in and it stays very stable. This one is nearly a 3-year video, and even today we follow the patient up. Patient is very stable. So the last of my videos is again a similar one. in which this is a more difficult rip. It is an eccentric longitudinal rip. So this was a posterior polar cataract, and we were expecting a problem because the first eye done by a colleague of mine had a problem. So again, expect a posterior capsular rupture if the other eye has had a problem, even if it is done elsewhere, because there could have been any difficulty. Now you can see that it's an eccentric rip, okay, but the vitreous is not there, and I'm placing viscoelastic, that blob of viscoelastic, between the tone posterior capsule and the anterior capsule, and then very, very gently in a very stable chamber, again landing it there. This is going to be a little more different because you have to twirl around the haptic and the optic, okay. So it has to go in absolutely in visual proper vision, that it has gone into that space between the posterior capsule and the anterior capsule, and then nudging it across, seeing that yes, it is there, and checking also the edge of the anterior capsule. And again, this one is then a little easier, this haptic, the trailing haptic, which was again twirled out, and then it goes into the bag. So again, I would like to put a disclaimer to do it. So we show these cases, but it is not so that I can do this every time I have a PC rupture. Similarly, please assess the situation first, your own abilities first, and then go ahead. But it is always very important to be as safe as possible in a posterior capsular rupture. Thank you very much.
Thank you, Partha. Thank you. So,
thank you, Dr. Partha, for the beautiful videos and the beautiful presentation. One special comment on the trifocal IOLs. When you are putting the trifocal IOLs with the PCR, see, actually, even if you are nudging it properly into the between the anterior and the posterior capsule, see, posterior capsule is not going to support in that way as it's when it's complete. So very important point, because even if you have nudged it very well, you have to make sure that the lens is well centered. The centering is very important, because centering won't happen naturally as we do in the capsular bag. Here, when you have a PCR, you have to center the lens. You have to pull and push the lens right, left, up, down, and bring it to the center, and then put few drops of pilocarpine, constrict the pupil, and then see that your lens is well centered, because the constricting the pupil will definitely hold the lens in position also, and make sure that it will make sure that the lens is well centered.
Thank you, Rajendra. Thank you, Partha.
Thank you very much, sir.
So one important tip you should carry home massive with PCR. Number one thing, do not panic. Do not make havoc in the OT that your patient and staff both are conscious. Every anti-segment surgeon should know how to do vitrectomy, anti-vitrectomy. It is very, very important. If you want to learn, we can teach you in SSTC area. We are doing this for last 10 years. Anti-segment, every surgeon should be confident of doing anti-vitrectomy. Number 3 thing, everybody should have a circle fixated lens, 3-piece lens in their OT. So these are the few tips, but we are getting short of time. So thank you all, faculty, and thank you all of you for having with us. Partha, photo.